Hi, everyone. My name is Jeremy Harper, and today I'm going to talk to you about GLP-1s, the new weight loss drugs that have come onto the scene over the last couple of years. They're so popular at this point that we are seeing advertisements at the Super Bowl for them. So, my background is I've been a healthcare informatician for the last 20 years, and I built this presentation originally for the HIMSS Indiana chapter. And I thought, hey, look, I'll go ahead and package this up and just put it out on YouTube for everyone to have access to it. I'm going to teach you today a little bit about America's obesity epidemic, the fundamentals of GLP-1s, kind of their background. We're going to then transition into more of that healthcare informatics specific information, their impact on clinical practice, the reporting impact, and all the while we'll talk about some real world case studies. All of this is really important because this new ability to treat obesity is something that we've never had the ability to do in the past. Our best opportunity has been bariatric surgery, and this is a very different beast. So, obesity, why does it actually matter? One of the things that I, as a very large man, um, was shocked to find out is on average, BMIs from 40 to 44 were associated with 6.5 years of lost life. People just didn't live as long. And if you had a BMI over 45, it was 9 years. And over 50, it was 13.7. As someone whose BMI was over 45, uh, 10 years is not something that I am comfortable with giving up. I've got some young children and I want to be around. And so I have lost 100 pounds twice since I was 20 years old, and I've gained every pound back, and often more. And so, as a patient, as someone who knows how to eat right, but doesn't always do it, um, I have really been looking for a solution. I've had family members go through bariatric surgery, and I thought, oh, that is so hard and so many lifelong consequences. And for a variety of reasons, including a father who had esophageal cancer, which, if you do bariatric surgery, your treatment options for esophageal cancer are limited. I tried to shy away from bariatric surgery. So, one thing that you will notice is I am using a number of slides. Often the very colorful ones are coming from something called epicresearch.org. This is not a peer-reviewed research publication, but what they do have is Epic is an electronic healthcare record, which many, many large health systems around the nation are using. They are able to pull patient data on over 109 million patients and look at their obesity from 2010 through 2024 population level. And you can see here that when they pulled their data, they saw 40% of the population in 2010 and 45% in 2024 were obese. Overweight, 31 to 30. Healthy weight, 27 to 23. Uh, we are having fewer and fewer people in the healthy weight category. We're seeing obesity and severe obesity increase. You will notice something started happening around here where we started seeing these trend downward. That was around the time that these GLP-1s were starting to be widely introduced. And as you might imagine, those with severe obesity are the first targets for this drug. Every GLP-1 that the FDA is currently approved has expectation that you are only going to be using these drugs if you are a BMI over 30. And again, that goes back to what we know about your long-term health crisis. They did do a very nice job of just giving us some clear graphics over how has this been changing since 2020. So, why are GLP-1s different from what we've had in the past? In the past, in most healthcare settings, we don't even need to make systematic adjustments for most new treatments. most new drugs, we just put it into an electronic healthcare record. The provider learns about the drug and they order the drug and things continue forward. But GLP-1s are a little different. Uh, GLPs are hormones. They aid in glycemic control. While they have a wonderful side effect of appetite suppression, they were originally established for diabetic control and the first generation, a little over a decade ago. The second generation is what we're in now. That includes Ozempic, that includes Zepbound, and I'm sorry, we're in the third generation now. But there were two earlier generations that didn't have quite the same amount of weight loss and not quite the same amount of glycemic control either. And then we are currently seeing a lot of news out about the potential of the next generation of drugs and seeing even better um, results from it. And we'll go over the results in a second. The two main contenders are Zepbound and Ozempic. Uh, I will talk a lot about experience with Zepbound. Ozempic slash Wegovy is the same drug compound by Novo Nordisk. Ozempic is approved for diabetes, Wegovy is for just weight loss. And then we've got Mounjaro and Zepbound for Eli Lilly, which is based out of Indianapolis, where I happen to be located, but I have no affiliation with Eli Lilly. So both of these drugs, what you do is you give yourself a once a week shot with an auto injector. So here I have an actual auto injector. As an example, all you do is you pull the cap off, you twist this to an unlocked position. The cap is stuck out a little bit, like in this image with the purple. You click it, a needle injects this into your skin because you're holding it against your skin. And afterwards, all you do is you put it back together and put it into a needle safe compliance. Auto injectors are a modern miracle. They certainly make things simpler than they've ever been in the past. So, when we're looking at weight loss, what can you expect? This is a famous meta study where if you do diet alone, you can expect to lose nothing over 3 to 4 years. If you do exercise alone, you often lose some weight. This is in kilograms, so call it 5 pounds. And then you're back to normal around 12 months later. If I'm sorry, if the black line was advice alone. So if we do absolutely nothing but advice. If we do diet alone, we can see some more improvements. We'll often see people keep it off for 12 to 24 months. These are people who they know that they need to lose weight, they are motivated to lose weight, and by the 36 months mark, they are often close to where they started within 5 pounds. And very low energy diets or very low calorie diets, we can see very drastic weight loss in kilograms, but people tend to regress to the mean. In general, people are going back to where they started. This is a very nice, colorful image that I found from Vox, which was sourcing from the Journal of American Medicine Association. If we control every calorie, we can get some 14% weight change over 8 to 12 weeks. In some people want to talk about whether or not calories matter. In every situation where we have ever put someone in a room and we have controlled their calories, we know exactly within a margin how much they're going to lose. People lose weight if they consume fewer calories. Getting people to consume fewer calories has long been a big problem. This slide takes a little bit of unpacking. Tirzepatide is Mounjaro or Zepbound. That's the one where I showed you the pen. And Mounjaro and Zepbound are the same drug. It's Tirzepatide in the background of the system. Semaglutide is Ozempic or Wegovy. Semaglutide oral, uh, an earlier generation, lorglutide injection, and an earlier generation again, the dulaglutide. This is from, again, that EPIC research program, and the reason I like them is they know how much dosage has been prescribed for patients, and they are able to use very large numbers, 413,000 patients across all of these drugs, to give us some better reports back. And in particular, this system that they have collected all this data from hospitals, they're going to have some very powerful information both on what we are prescribing people as well as their actual weight. So, one of the things that I didn't mention for Tirzepatide, it comes in 2.5 is your starter dose for 4 weeks, 5 milligrams, which is this column here, for 4 weeks, 7.5 for 4 weeks, 10 milligrams, which is considered the therapeutic dosage for 4 weeks, 12.5 milligrams for 4 weeks, and then 15 milligrams for 4 weeks. And 15 milligrams is where it maxes out. Similarly, semaglutide goes in these 1.7 to 2.4 dosages. And the reason why we introduce them 4 weeks at a time is when we just give you 10 milligrams right out, you tend to have a lot more side effects and you are a lot less likely to go actually take the drug because you're having so many side effects. Introducing it to your body over time has proven to be more effective and more likely that you're going to be willing to continue taking these drugs. The other important thing about this image is you'll notice that this is after 1 year, so 52 weeks. Most of the reporting that is done by the Novo Nordisk and Eli Lilly and the research studies they commissioned actually look at a year and a half. Most people peak whatever weight loss they're going to achieve around that year and a half mark. So the other important thing to note and just be thinking about in the back of your head is most of the people who were taking these drugs, most of the 400,000 people, were on it for diabetes, not for weight loss. Weight loss is a wonderful side effect that they may have achieved. And so we still don't know for those people who are on it for weight loss what their realistic lifetime is going to look like, if they are going to also peak after a year and a half, if they're going to peak longer, shorter. Maybe they're peaking shorter because they're spending a lot more energy trying to do diet and exercise, and they hit their natural transition point. So, if you remember the images that we were looking at just a few minutes ago, where we were looking at what the potential weight loss percentages are. Again, if we restrict all of your calories and get you down to 500, 1,000 calories a day, we can get you to a 14% weight loss in a very short amount of time. It tends not to be sustainable unless we continue giving you that very low weight loss. At 5 milligrams across a year, people lost 8.6% of their body weight. 13.2 for the higher milligrams and 15% for 15. I think with Zepbound in particular, you can expect somewhere in the 18 to 20% range after a year and a half. And that is the median. For semaglutide, the median's more in the 7 to 8% range across everybody. And that is why I personally would recommend, and personally I'm on Zepbound, but semaglutide has been fantastic. Ozempic is what you've seen a lot of people talking about in the media because this came out a good 2 years before Zepbound was approved. This is another EPIC research study that is on a completely different evaluation metric. And so it's only looking at 186,000 patients, and it's specifically looking at bariatric surgery. But I really liked this graph that they produced. And you've got your first generation and then your second generation, or I'm sorry, third generation of these GLP-1s. And on this metric, it's the percent of patients who experience different weight loss in the year following this bariatric surgery or starting on GLP-1s. So if we look here, 10% of patients had a weight gain if you're on the first generation liraglutide. Very few patients for bariatric or any of the others had any type of weight gain. You're in the very small percentage. And whether that's because they discontinued or what's going on, we don't know. That'll be teased out over time. If you are on bariatric surgery, very, very few percent have less than the 9% weight loss here on this. You'll see that most people can expect greater than 10%, and the median starts hitting that 20 to 25%. And frequently people see 40 to 45% weight loss as achievable. One of the things to keep in mind is the population who's doing bariatric surgery tends to be self-selecting, those people who are highly motivated, as well as who have a high amount of weight to lose. Currently, a lot of these drugs are hard to access. There has been major shortages on these drugs, and so as these shortages are loosening, as there becomes a wider number of people who are aware of these drugs, it's very likely that we will see Tirzepatide and semaglutide have their numbers skew even more to the lower amounts of weight loss, because the people involved will just need to lose weight to less weight than someone who is 45% over BMI. But still, you can see with semaglutide, you have the peak, the median here at in that 10% range, and Tirzepatide in that 15% range for what you can expect to lose over that course of the first year. This is just looking at the Zepbound study that Eli Lilly released, and just giving you, here's what people with coaching and dieting accomplished with the placebo. Here's what they accomplished with the 5 milligram, the 10 milligram, and the 15 milligram. So 5 and 10 for the first 24 weeks were right. I'm sorry, 5 and 10 for the first 16-ish weeks were right aligned. And the first 24, the 10, 15, and then those who were on 15 milligrams lost an even higher percentage. So, what does 10% look like in real life? I have been on these drugs, Zepbound in particular. That's why I have the shot available to show you what it looks like, how you actually do the self-injection. And again, you just put it up to your body, click the button, and it injects the shot in you. It can't be easier than that. This is 10%. It is awfully nice. One of the interesting things for me, and what is widely reported, is as soon as you start taking the drug in the first week, you lose what's called food noise. And food noise is somewhat hard to describe, but essentially, I was always thinking about food. When was I going to eat next? What was going on? I don't think about food anymore. I have some, I have a lot of habits around food where I tend to go snack, I tend to go eat. It is much, my body is not going and telling me that I need to go snack and I need to go eat nearly as often. A lot more of it centers around my habits and habits that I'm working on breaking. Um, it is very interesting to go on these drugs. For me, there was, I had read every research study leading up to this, and so I was looking for everything. For Ozempic, there has been a research proven correlation with depression. And so I was having my wife check me for depression every week as I was starting these drugs to see if that was something that I was going to see. Zepbound hasn't had that proven in research. There's still a lot of unpacking and teasing out that we're going to be doing over the upcoming decades. How much of this is depression? How much of this is, hey, I was masking other things going on in my life with food? I'm blessed in that I wasn't masking anything with food. I like food. I really like food. Um, I know how to lose weight. I know how to eat right. I know how to exercise. I've lost 100 pounds twice in my life. These days, I now wonder how much of that was hormone driven rather than driven by at the time I just described as, well, I really want this, and I'm much more motivated to accomplish it. And it's really interesting. For me, there was a really big mental um, barrier, mental jump, mental leap uh, in dealing with just a drastically changed behavior pattern from taking a hormone. I did not perceive myself as being so controlled by my hormones to see myself overnight, essentially, literally overnight. I was uh, some people have faster reactions than the others, and I reacted faster than most people. And uh, dropping and not eating more than 1,000 calories a day. I dropped probably around to 2,000 calories a day, and I'm probably around 2,500 calories a day right now. I've actually not been losing as much weight the last couple of months because it's winter, it's in the teens, and I just don't go out and exercise nearly as much as I should. Um, these are life choices. I'll exercise more over the summer. I'm keeping a close eye on one of the side effects that people report a lot is muscle mass loss. How much of that is actual muscle mass, and how much of that is just the fact that you're eating fewer calories? We haven't teased apart yet. Uh, for 100% side effects, a lot of people report nausea at some point along the way. And sometimes you can have nausea after having successfully taken a dose for 3 weeks, and then the fourth week, you just have a lot of nausea. A number of people have experienced vomiting, diarrhea. This reports 10 to 20%. If you go look on the Reddit forums and the Facebook forums where people talk about these things, uh, your bowels, your diarrhea, constipation, um, there are a lot more people having side effects than what this reports. A lot of the early research studies also came with diets, and diets that may have been smarter on your body than what many people who are getting these drugs are doing. If you have been used to going and eating a bag of chips all the time and greasy foods, maybe your body is not going to like that as much with some of these new hormones that you're taking, and you're going to experience even more problems. For myself, I tend to be in this camp for the first few days of the shot and this camp for the last few days of the shot. And it hasn't mattered what dosage I'm taking. And I consider it mild where I wouldn't even report it. Uh, it's just something that I live with at this point. Um, Injection site reactions, anytime you inject yourself, you're going to have mild irritation potential. Um, uh, because we're using the auto injectors, it's very interesting to me. They don't even recommend that, oh, you go get alcohol prep pads, which I'm a, hey, look, I know that most likely I don't need it. After I did the research, I understand why they say, but I'm still going to do it because it might as well be a little safer than sorry. I can afford to use an alcohol prep pad. Um, There are other side effects, though, that are more important for us to pay attention to. The depression side effect is something to be, if you are someone prone to depression, you should be aware of it. Because suicidation can come on rapidly for people who are prone to depression. And you, it's not a reason not to take the weight loss drug. In general, the research that I've seen that reporting it tend to be saying that it's an increased amount of depression. It's not driving people to suicidation. Um, I'm just having a few more bad days in the week, but it's something to be aware of. Pancreatitis and gallbladder disease, and I didn't make it on this list because it wasn't research proven, but a lot of people have reported they're getting kidney stones more often. All of those things are how much is the drug and how much is the weight loss? Still needs to be teased apart. Right now, we know that it is associated when you start taking this drug. Turns out that if you are going to do rapid weight loss, gallbladders and pancreatitis are also much, much more common. And something to be aware of also is in rodent studies, they have seen increased risk of cancer with these drugs. And so thyroid cancer in particular, so they don't, if you have a family history of thyroid cancer, you have thyroid cancer, these drugs they recommend against for you because we haven't teased apart does that rodent study play out in the human ecosystem. We'll probably see answers to that over the next couple of years, since we do have a fairly large number of people who have been on these drugs for a fairly substantial amount of time. Even if it's in diabetes, we can look at that population and tease that apart. The other thing to be aware of is this is probably a forever treatment. Um, there was a single research study that was done that meets research capabilities that's looking at, okay, if we give you Tirzepatide, what happens after we give it to you for 36 weeks, and then we take you off of it or we keep you on it. Where is your weight loss? And only 1 in 6 people were able to sustain their weight loss after stopping Tirzepatide. Now, I will say, I look at some of this, and for myself, I have been the type of person who would go and would take a 3-day fast, and afterwards my stomach would be smaller and I would be eating less. Um, Tirzepatide with the sheer number of fewer calories, for someone who was close to 400 pounds, I was eating probably over 4,500 calories in a day. To go down into the 2,500 calorie a day range, my stomach is smaller. Even if I went off it tomorrow, my stomach would take some time to regain that size and expectation. And so, how much of this is going to be forever treatments and how much of this is coaching and training and weaning off, we don't know. I will say, going back to the food noise would be mildly depressing. Now, let's look at the cost. The cost is substantial. If you are paying out of pocket with no discounts, you're paying $1,300 to $1,500 a month from your pharmacies. That's $13,000 to $15,000 a year. It's a lot of money. For Zepbound, they do offer a coupon code. If you're like me and you got it early enough, you can pay $550 a month for the Zepbound dosage. If you went and applied for it today, it's $650 a month. The expectation is sometime mid-year they're going to move all of us on the 550 up to 650, which will make me very, very thrilled with these drug programs. Now, Eli Lilly has not testified to Congress that I have found Novo Nordisk did. It costs them about $20 a month, $5 a shot to produce these drugs. Eli Lilly appears to have essentially the same cost. As someone who is taking these drugs, I have a bone to pick with the fact that we are not capping their profit margin. This feels like the same behavior that we saw with Martin Scarelli with diabetes, where we've got a national health crisis and we're gouging people. I hope our Congress goes and does some negotiation. I think that they should absolutely make a profit. But obesity, as you saw, is a major health concern for our nation, and we should deal with it. There are two other things that I'm going to bring up, just so you're aware of. There has been a compounding pharmacy option. In that is rather than $6,600 a year, that is in $3,800 a year range, maybe $3,400 a year range. Compound pharmacy, for those of you who aren't familiar with the concept, is they get Tirzepatide in its raw form, and they do things that are off-label. So maybe you didn't, maybe you had major side effects at 2.5 milligrams, and you need it to be a smaller amount of dosage. Maybe you need it to be in pill form. These are the people who do all of those things. Compound pharmacies are very important for drugs that are not economically feasible to produce in mass. Eli Lilly and Novo Nordisk want their profit margin, and they are fighting to get the compound pharmacies shut down for these drugs because they are still under patent. I disagree with them. Compound pharmacies, in general, are completely safe. They are operated under state-run oversight rather than national, and so there are some mild things that are different about their expectations, and it can be mildly different between states for the cleanliness and their drug manufacturing capability and things along those lines. I consider them safe. When my wife and I discussed it, she felt more comfortable with having a 2-year-old and one on the way, that we would just pay for the regular dosage from Eli Lilly. And thankfully, we're in a financial position where we can do that because, again, I'm on the coupon. The coupon is only available for those whose insurance is not covering it. Now, there's also illegal drugs coming in for GLPs, and those average around $125 a month or $1,500 a year in cost. Overall, they're being produced in China, and they are violating their patents. And I'm not going to encourage you to pursue that route. There are dangers with it, and even the most safe people who are pursuing that route are going through and needing to send in what they are sourcing to laboratories. They're risking penalties because it's illegal. And they're risking having some major complications. Someone who is in the industry was talking to me one time about the fact that when you're sourcing from these manufacturers, you also risk, there's a very low probability when you are using the exact patent that has been provided that you will start producing antibodies against the drug. There is a higher percentage likelihood when people allow additional impurities to come into a drug manufacturing process, that they are more likely to wind up with their body rejecting these drugs and then never being able to use these drugs in the future. There's also something else to be aware of. Well, there are many other things to be aware of. As for Zepbound and Novo Nordisk, Wegovy, when they sell you these prepackaged auto-injectors. They sell you the 2.5 milligram or the 15 milligrams of the drug. You pay the exact same amount. There is a fairly large body of people, even people who are having insurance covering it, who are working to get the largest amount of dosage prescribed to them, 15 milligrams. And then they go old school and they treat it like we did insulin shots that you were probably growing up with, where you inject this auto injector into a vial, then you put in what's called backwater, but it's alcohol water, which prevents a bacteria from growing. And then you use an insulin needle, you pull it out of the vial, uh, and you use alcohol wipes and you inject it yourself. And so that 15 milligrams, if you are someone who is responding very well at 5 milligrams, you can split it to where it's lasting you uh, 3 weeks instead of taking it in a single week. And so if you happen to be someone who 5 milligrams is working very well for you, you're taking your cost from $550 a month to $185 a month or $2,200 a year. And so this is being frequently seen. We saw this, providers are getting cracked down on if they are just prescribing you 15 milligrams without you having like a history of ever being on this. But providers want to save you money. Like, there are numerous providers who will coach you through this and teach you about this. This never appears on our medical charts. That's going to be a problem for us in the healthcare informatics industry. Now, one other thing to be aware of is there is a fair amount of fraud. CNBC released a couple months ago a video on Ozempic's underworld, and we see this most frequently in med spas. So med spas are organizations that you can find in most major cities and even smaller places where they're the people who have been freezing fat. They're the people who have been injecting to help you look more youthful. And so this fit within their niche. They bring you in, they give you the injection every week. Maybe you get what other touch-ups that you're interested in. If you are not sourcing your drugs directly from a pharmacy, uh, there are people who are creating fake manufactured Ozempic pens and Zepbound pens and selling these and purporting them to be the real thing. And when our FDA has analyzed some of these counterfeits, they found that sometimes they contain what they say they do. Sometimes they contain insulin instead of semaglutide. Uh, it is a public health risk, and educating yourself on it and understanding it and making sure that you are sourcing these things through pharmacies directly is my recommendation. Oh, I've got a friend, family friends who own a med spa, and every time I post about how wonderful this is, they advertise a med spa on my social media accounts. And I've been very blunt in posting that in general, med spas are really not recommended, and a lot of people have wound up getting hurt by leveraging them. I'm not ever going to say that my family friends have anything but the best interest in uh, the people that they are helping, um, but it's an industry that is looking to meet a need, and sometimes attempting to meet that need has resulted in potential harm. Just a couple last slides. Patient care to be aware of. Ozempic actually has a half-life of 7 days, so you taking it every 7 days makes a lot of sense. Your steady state concentrations are achieved 3 to 4 weeks after you start taking the dosage. Zepbound actually has a half-life of 4 to 6 weeks, or I'm sorry, 5 days, and it takes 4 to 6 weeks to accumulate and maintain the therapeutic efficiency. This is important because if someone is coming into a healthcare setting, we don't necessarily have to spend a lot of energy worrying about the fact that they are on these drugs. Their body will naturally be slowly titrating themselves down over time. And uh, something to be aware of, though, is in general, people can't just, if they're on 10 milligrams, they can't just go back to 10 milligrams. They have to restart the process with wherever their half life has gone down to. So if they have a longer health hospital stay. Also, to be aware of some of the people who think that they're on these drugs and reporting that they're on these drugs, if they happen to be on the fraud drugs, um, very likely uh, it would impact their hospital stay in a very negative way if they think they're on 10 milligrams, they're not on 10 milligrams, and suddenly they are given 10 milligrams, as an example. Now, insurance motivations. These are incredibly expensive lifetime drugs. Um, you know, I was a business major. I like looking at what insurance companies are reporting and what Eli Lilly and Novo Nordisk are reporting. Most of the insurance companies have negotiated something where they're paying that 550 to 650 a month price tag, not rack rate of 1100, 1200 a month. Some insurance companies haven't. I remember a big article, I think out of Tennessee or Georgia, where it was just bankrupting their insurance the first couple of years because they hadn't allocated millions and millions of dollars to pay for these drugs, and they were paying rack rate. So insurance companies have been putting more and more barriers in place. So in December, like the last week of December, the FDA approved Zepbound for sleep apnea. It's new enough. Insurance companies haven't built a lot of barriers yet, but the expectation is by next year, we will see insurance companies say, hey, look, if you are having a good time on your sleep apnea machine and it's working for you, we're going to insist that you continue on your sleep apnea machine and don't take Zepbound, even though you may meet all the criteria for Zepbound. A sleep apnea machine is in the $1,000 to $1,500 price tag for 3 to 5 years, and 2 months, and you've already gone over that with Zepbound. And so here in Indiana, the entire Midwest, we've got a pretty big obesity epidemic, and insurance companies um, understand and can calculate the fact that those people who go on these drugs are going to lose weight and are likely to have fewer problems. And they are often the people who have bigger complications and problems, but it's not offsetting for them at this time with the price tags that we're looking at a population level. And so, in general, most organizations are seeing major prior authorization delays where they have to do multiple iterations of prior authorizations. Patients, and this is the last little bit for electronic healthcare record impacts. Patients shouldn't have their prescriptions auto-canceled just because they don't refill, especially when they're uninsured. They may be splitting. Um, we also have seen a lot of kind of bad data potentially being introduced over time, where physicians are coding people so that they qualified under diabetic drugs, and maybe they didn't really fit the diabetic categories very well, but then that impacts our resources within hospitals, our follow-up capabilities, and it's something to be aware of. We've also seen that alerts over patient weight loss need to be adjusted on these drugs. We are expecting them to lose weight. We might actually need to alert if they aren't seeing weight loss, so for conversations to be occurring about that. We need to look at um, adding the ability for patients to report the effective dosage, where they're not going to get penalized if they tell us, hey, look, I'm actually on 5 milligrams, but I'm getting prescriptions for 15 milligrams. We also have to think through just how we're setting up alerts and reminders, thinking about what happens during missed appointments. Uh, you know, we normally prescribe this for 2 or 3 months at a time and ask people to come back and do follow ups. And if they miss that appointment, restarting this drug regime can be challenging. Um, and so, what's that look like? Talking about that with the patient early, it can be pretty important. We need to think about the lab monitoring. Most patients who are going on these drugs need to be taking labs, and they also have to have a whole education process. And we'll talk about education on the next slide. But a lot of the information that we're getting may be biased within everything. We also need to think through just what like remote monitoring is going to look like for these patients. So with patient education, you need to think through in the near term, we need a lot more dietitians, nutritionists, and behavioral health specialists like psychologists and health coaches than we've ever needed in the past. In the long term, that's probably not going to be the case. We don't want to train a giant swath of new providers and then not need them anymore. And so we're going to be focusing instead on doing this delivery through electronic education, and we're going to solve it with technology. So we need to think through how we're going to solve that with technology and how we're going to deliver it. I've talked to a number of companies that are figuring out the patient education piece, and estimates differ, but somewhere between 60 and 80% of people who have extreme obesity probably need some type of behavioral health specialist in addition to dietitians and nutritionists, because there are some other things going on in their life and their background that is causing them to uh, self-soothe. A lot of our compliance reporting is going to be faulty because of people sourcing drugs in unique and interesting ways and splitting drugs. Our reporting on dosage for weight loss is very likely to be inaccurate over time. Unless we are physically giving you the dosage, I consider it suspect. Side effect reporting. We don't do a great job of collecting that right now, and thinking through how you're going to collect that, if it's going to be important for your health system. You Right now, we're only going to get it if it's an extreme side effect. We're not really going to know what percentage of our patient population is going to have a side effect versus another. And we just need to build a lot more patient progress tracking. How are we going to encourage them and help them on their journey? 20% weight loss is life changing for most people. Uh, if you are 300 pounds, that's 60 pounds weight loss. 400, it's 80 pounds. 200, it's 40 pounds. And to go from 200 pounds to 160, it really can have a huge impact on people. We also need to think just through our population health. GLP-1s have to be reflected on our population health dashboards to help us identify trends and optimize workflows. People who are on GLP-1s may well need to fall into different categories than what their raw numbers might tell us. And just think through how you're going to do remote monitoring. I have a lot more to say about remote monitoring, but I've gone long. Just my final thought is this drug isn't a panacea. There are a lot of patients facing a lot of stigmatization with obesity. Uh, People saying it's your fault. People saying that you're you're just not having enough willpower. And well, I think that we are going to start seeing a cultural shift over the next couple generations because, I always described it as, yeah, I just didn't feel like it. I didn't have the willpower to stay on the diet. And then I took the hormone, and overnight I didn't have any, willpower problems. It wasn't a lack of willpower. It was just I had hormones driving me. And it's going to take some time, but for now, we're still going to see patients facing a lot of stigmatization for extreme obesity. And so, with that, that ends my presentation. Leave me questions in the comments, and I'll do my best to get back to you. Thank you so much.